Good afternoon, all of you. We are here to discuss a very interesting panel discussion, child with chronic hypoxia. And for that, fortunately, we have very eminent speaker from around the world. And I quickly want to introduce all those our speaker. I am Prawin Kumar. I am working as an additional professor at AIIMS Jodhpur. In the list, we have the lead discussant, who is a very renowned pediatric pulmonology from the Birmingham Women's and Children Hospital, UK. We have another 4 eminent speakers in the list for Dr. Biju Thomas. He is working as a head of service in pediatric pulmonology at KK Women's and Children Hospital, Singapore. The second is Dr. Krishna Mohan Golla. He is working as an associate professor in AIIMS Bhubaneswar. The third is Dr. Nitin Tochak. He is a senior research associate at AIIMS New Delhi. And fourth, Dr. Salini Tyagi. She is from Noida, Delhi. So before losing any times, I'm going to start. And what we do, we will discuss 2 cases. And in between, we'll take the questions from the panelists. So this is the case 1. I'm going to start with the case 1. This is a 15-year-old boy having presented with complaint of cough for 1.5 years, breathing difficulty for 1 year, and loss of weight for 1 year. Cough was insidious in onset and predominantly dry in nature. There was no any diurnal variations, and cough was exacerbated by exertions. There is no any post-stressive vomiting, and there is no any noisy breathing. Similarly, difficulty in breathing was also insidious in onset. It was progressive, and now currently the child was on MMRC grade 4. It was also exacerbated by exertion and relief or rest, and it was associated with palpitations. On further history, there was no history of fever or loss of appetite. There is no history suggestive of any cardiovascular disorder. There is no history suggestive of any autoimmune or connective tissue disorder. There is no any history suggestive of any hematological disorder, and there are no any history of TB contact. He received bronchodilator, but there is only partial response to the therapy. Regarding the exposure, he used to go to the form of cumin, that is the jeera. He is a jeera form he used to go. And on leading questions, there are sometimes he point pigeons in the form, but it was not very strong association. So I would like, from this point of time, I would like to, from the Dr. Krishna, what is your first clinical impression on this much information? Can you give mic, please? Mic to the panelist. What is your first clinical impression, and what could be the possible differential diagnosis on this much information?
Thank you, Dr. Prawin. So, because we are in a respiratory conference, so obviously the possibility will be related to the respiratory disorder. So, if you go by the history, the child is having predominantly dry cough, and it is progressing over almost over the few months. And he is hypoxic and getting exertional dyspnea. So as a pulmonologist, when you look at this type of patients, I would first think of some disease process that is involving either lung parenchyma or alveolar membrane.
Good.
So, but this is the anatomical diagnosis in which I will be interested in. But the other common disorders like asthma, so even though it is dry cough, but if you look at the symptoms are almost continuous, they're not intermittent, and there's no much response to your bronchodilators or so. And other symptoms like stridor, wheezing are also, they're not forthcoming in the history. And other is, I could think of, when you're taking history, you need to look at the importance of exposures. So it is you should not be very casually asking, because there is no part in the country where there are no birds or so. You need to have some amount, there are some guidelines to what is the amount of exposure and how much type of exposure, duration, all these are also needed. Okay. So from this history, I can say that it is involving something that is related to lung parenchyma or alveolar membrane.
Okay, thank you, Dr. Krishna, very well said. Now, moving to the further history, there was history of, he took ATT for 1 month, but he stopped itself because there was no improvement. There was no basis for starting ATT. Past history and the birth history was normal. Immunization history was up to date. Developmental was also normal. And on the diet history, he was deficit in 30% of calories. Family history was insignificant, and he belonged to lower socioeconomic conditions. on examinations, he was tachypneic, on hypoxic, maintaining 84% on room air only. On examination, he has pallor and grade 2 clubbing. Anthropometry, all are less than third standard deviations. On the systemic examination, upper respiratory tract was normal. In the respiratory system examination, child was having the flat chest, and there was intercostal retractions. But on palpations and percussion was normal, but on auscultation, there were fine crepitation on the bilateral chest. So at this point of time, from Dr. Nitin, I would like to ask of you, what is now your thought process? Can be it ILD, because I have just heard about the ILD. So what is your thought process till now?
So what we find after examination, after the history, we know that there is a chronic respiratory problem with a dry cough. And so we are thinking more of towards conditions which cause dry cough and respiratory distress. So interstitial problems, they come upfront out here. And like Dr. Krishna already discussed, that there is not much of variability. So, and it's more of a persistent disease which is gradually progressive. So keeps asthma at lower down. And on examination also we have features that there is some chronic hypoxemia, child has clubbing. And the examination findings are showing fine crepitation. So I'll go, definitely it looks like a textbook case of an interstitial lung disease. And again now we will have to probably for the how to work up further, we will have to see which of the ILDs does it fit in. With some exposure of history of exposure, we would think of whether HP is one of the possibilities. There is a lack of systemic features, so no fever, joint pain, all that. So maybe less likely to be connective tissue related ILDs, but still maybe sarcoidosis or these we will have to consider. So we will have to consider some acquired ILD. Another thing here is that we have a loud P2. So that is a surrogate of that there is some pulmonary arterial hypertension. So that here with the crepitations and cough, I will think that it is secondary to interstitial lung disease rather than a primary pulmonary arterial hypertension.
Okay, thank you, Dr. Nitin. And just I want to highlight that in Indian scenario, when to suspect ILD, whenever there is a respiratory symptom, whenever there is a respiratory signs, having some hypoxemia and having the bilateral diffuse finding, whether on the X-ray and clinical finding, then we should suspect ILD. Moving ahead, on investigations, most of the investigations are normal except a slightly raised CRP and ESR. The TB workup was normal and HIV was also normal. This is an X-ray of this child. So here I want to ask a question from Dr. Salini. What is your interpretation from this X-ray?
Is it on? The X-ray, Dr. Saab, it looks dirty, like it's involving the entire lung. The word is diffuse, you know. I can see reticular pattern, and I can see it more on the left side, and there is some lung volume loss on the left side, the trachea deviating to that side. You can see some bronchiectasis, some traction kind of bronchiectasis happening as well.
Okay.
So all in all, it's a disease process involving both the lungs.
Okay. Does it help you in giving any specific clue to in the context of giving clinical picture? Does it giving any clue?
Of course it does. So it rules out a lot of things, you know.
Okay.
That we start with, you know, the common, we in our country, we have to rule out the infection first, whatever said and done. So it is not going in that favor, that's one. And second, the reticular patterns, yes, I would want to look for.
Okay. Thank you, Dr. Salini. Before moving ahead, I would ask from just discussed in the previous class, how spirometry will be helpful in approaching such type of children?
So here in this scenario, if we see this X-ray, we have some diffuse involvement, right? Okay. So here spirometry, and probably with this we have some suspicion of that there is some diffuse involvement, parenchymal involvement, but it will be very hard to make a definitive diagnosis of ILD on this. Okay. But certainly that will be our first suspicion. Okay. So a spirometry and a high contrast imaging like a CCT, high resolution imaging will be required.
Okay. This is the spirometry of this child. So, Dr. Nitin, what is the interpretation from this spirometry picture? Sorry.
So, this is a forced expiratory curve, and what we can see here that the effort is good, so it is going up to around 5.5 seconds. Okay. So that is there. Then I'll come to interpretation. So I see FVC, the predicted is 2.51, and this child only has 0.61. So which is 24% of predicted. FEV1 is also 27% only. And the FEV1 by FVC ratio is 100%. So we know that here that FVC is significantly reduced, but the ratio is maintained. So it's a purely restrictive disease that we are dealing with.
So, well said, Dr. Nitin. So, we have seen that spirometry have also a very good role in approaching such type of children. So, now moving to the next investigation, which could be the next investigation, Dr. Nitin?
So I'll go for a
Okay.
HRCT with
Okay.
CCT.
So, this is the HRCT. Now, I invite Dr. Biju Thomas. So, what is your interpretation from this CT scan? This is the mediastinal window and this is the lung window. So, first I am putting the mediastinal window.
Yeah,
What is
yeah.
your interpretations?
Yeah, thanks, Dr. Prawin. Yeah, so we've got this contrast enhanced CT scan. These are the mediastinal windows, 2 images that you see. I don't see any significant mediastinal lymphadenopathy. The pulmonary trunk appears to be somewhat prominent. Maybe there's some early pulmonary hypertension. Can you go to the next images?
Okay, please.
So these are the axial images, lung windows. We've got 4 slices here. Looking at the shape of the trachea, it appears like expiratory phase. The image has been acquired during expiratory phase. Yes, again, there's bilateral diffuse changes. What we can see clearly is bilateral diffuse ground glass changes. That is quite convincing, I would say. The second image on the right hand, the top right hand, you can see a bit of focal air trapping on the right side. And the lower images, you can see a bit of differential lucency, a bit of mosaic attenuation kind of pattern, although I wouldn't say it's very, very striking, but it does appear like that, on the right side especially. The bronchial walls appears a little bit thickened. There doesn't seem to be much fibrosis that I can see. Again, in the context, like, I'm just looking at the history as well, there is exposure to FAM and the birds and all these things. So HP has already been mentioned. In that context, if you look peripherally, especially in the lower images, it appears to be there's some centrilobular nodule, some nodular pattern if you closely look. Dr. Mahesh has shown you a typical CT before. This is not as striking because these densities usually appear better visualized in inspiratory phase, maybe a limitation of the CT scan. So consistent with ILD, what type of ILD, I can't be sure. Maybe findings are non-specific and be overlapping with a variety of ILDs.
Okay. This well said, Dr. Viju. So what will be your next step? Should we go for the bronchoscopy or biopsy or the genetic test?
Yeah,
what will be your choice?
Yeah, in this trial there is history of exposure, we already mentioned, so that is on our minds. So I would probably go for BAL plus or minus genetics first because they are less invasive. Yeah.
Okay.
And
Thank
infection
you.
also is on the cards.
Okay. Thank you. That treating unit went for the bronchoscopy, and bronchoscopy as was normal, but this is the BAL report which saw the predominantly lymphocyte. So here I would like to ask a question from Dr. Krishna. What is your interpretation from this BAL report? Does it helping you in the context of given patients?
Yes, as expected, anatomy is normal. So when you are looking at the BAL picture of any suspected ILD, we need to look at what is the color, as already the previous speaker has told. It gives some idea. If it is the color, if it is white, then we suspect you are dealing with some PAP type kind of ILD, or it is hemorrhagic, or you are dealing with DAH, secondary to some autoimmune disorders also. Or if it is clear that it will give you, then you need to go for cellularity. So even though there is no normative data of what is normal cellularity in a BAL, you see, usually we say that 200, 300 cells per millimeter cube may be a normal predominantly of alveolar macrophages. So if you are having predominantly neutrophilic inflammation, that means you may be dealing with some type of infection. Or if you are having lymphocyte predominance, you see, if you have facility in your setting, you can go for the marker CD4 or CD8. It will give you some idea. They are not very specific or sensitive whether to differentiate between hypersensitivity or sarcoidosis. Again, it is other reports and other clinical condition scenario you need to interpret in conjunction with. But isolated BAL lymphocyte count, you can't say that it is HSP or it is sarcoidosis. And other is if you have macrophages, hemostimulated macrophage, that will give you some idea. And this is what that we can think of. But again, in this condition, before going for bronchoscopy, because in our setup, we don't do this BAL CD4 CD8 counts. Okay. Because the history, you have the exposure. First, I would go for somewhere less invasive. That is blood panel for hypersensitivity, pneumonitis, IgG antibodies against the avians. Then after that, I would have thought of going for bronchoscopy.
I agree with your point, Dr. Krishna. So, agreeing with your points, so this HP antibody panel was done, and it was strongly so positive for the pigeon serum proteins and also with the penicillium antigens. Echocardiography was also done, and it was so the mild pH. And the treating unit make a final diagnosis of interstitial lung disease due to the hypersensitivity in pneumonitis with mild pH. But I want to ask a question from Dr. Biju Thomas. Do you still think this child required lung biopsy or any genetic test to exclude the other ILD?
So you're giving the tricky question to me. So anyway, this one, I think if you look at the history, the exposure history from sort of birds exposure, precipitants, positive HRCT findings, I would say compatible. There are many features. And BAL lymphocytosis. So we could pragmatically say HP is a very highly diagnosis, top on the list. But am I 100% certain? I would say no, because of the limitations of the CT I mentioned. We don't really see the classic 3-density sign. And again, images were acquired during expiration, so we couldn't really see okay, there are some nodular lesions, but probably not very, very typical central lobular nodules. And BAL lymphocytes, I would say borderline. So I am not 100% certain, but I would say on the balance, I would be comfortable labeling as HP. Yes.
Okay, thank you. So this is a very good guidelines for the hypersensitivity in pneumonitis from the chest, which came in 2021, which confidently said if your antibody exposure is present and CT scan is very characteristic, then no need to do the lung biopsy and the genetic test. Very well said, Dr. Biju. And so that treatment was started in the form of MPS pulse in the low doses 10 milligram, apart from the other supportive therapy, oxygen supplementation, and very important, the antigen avoidance measures. ACQ and the supportive therapy for the pulmonary artery hypertension in the form of diuretic was also started, and child showed the significant improvement, and oxygen was weaned off gradually, it was weaned off, and child was discharged on D16 of life. Now, here I would like to bring our lead discussion. What is your overall comment on this case, and how will your clinical practice if the same case in your setting, sir?
So thank you. I think as Mahesh alluded to, the first step in considering interstitial lung disease is to consider the possibility of interstitial lung disease in your differential diagnosis. Now, if I was seeing this young lad for the first time in the clinic, I mean, of course, by the time he presented to you, he was quite sick. Okay. His symptoms are of cough and breathlessness. So naturally, the tendency is to label as asthma. So cough and breathlessness equals asthma. So cough, there is an excellent paper from Sheila McKenzie that goes back to 1983 or something like that, where she looks at various symptoms and how specific or sensitive they are from asthma point of view. Just a cough with breathlessness, with no other wheezing, etc., should help us move away from an asthma diagnosis. Okay. But that said, that is what we face every single day in our clinical practice. So we are looking for a needle in a haystack. I think that's the first alarm bell, is a progressive cough and progressive breathlessness that should alert us to a much more significant diagnosis. So if you had seen this young lad, 6 months before they came to you. Now, what was striking is the degree of hypoxia. Okay. And, that was striking. Yeah. So, of course, there are other conditions to consider, but we are in a interstitial lung symposium. But interstitial lung disease is one of the main sort of differential diagnosis so that we would actually look at. Now, in terms of hypersensitive pneumonitis, we have actually touched on that. Otherwise, you would consider immunodeficiency. Some immunodeficiencies do present in young adults. And then there is the autoimmune conditions that you would have to consider. Yes. So those would be your three main differential diagnoses, I guess. In terms of the lung biopsy in this case, when you have, it is reasonable to actually treat on clinical grounds, and I agree with Biju that there is enough on clinical grounds to administer steroids. Now, the question is, would you go for 10 milligrams per kilo of
Yes.
methylprednisolone, or would you go for 30 milligrams per kilo? Now, personally, I would have chosen 30 milligrams per kilo.
Why, sir?
I have not got any evidence to actually show it is more effective, but it is just the degree of restriction, and my anxiety is we don't have a lot of time to reverse this.
Okay.
So he's about 24% was his FVC, if I remember correctly, and he's severely hypoxic. So I would probably go very hard, aggressively at it, knowing that if it is a condition that responds very well to steroids.
Okay.
So I would have probably gone for a bigger dose of methylprednisolone. But if you ask me, is there evidence to back that? It is more anecdotal what we are actually used to.
So, thank you, sir. And at this point, I want to take a very quick comment again from you. So, after we all know the first line treatment is the steroid. In your clinical practice, what is the second line option for the ILD? Sometimes they don't respond with the steroid also. So, what is your clinical practice about the second line of treatment in such scenario?
So, I mean, hypersensitivity pneumonitis is, we would have to question the diagnosis if they didn't respond to steroids, because it is a steroid-sensitive disease. So if they didn't respond to steroids, then obviously I would be looking at, biopsying or chasing the immunology and the genetics a little further. But if we were talking about interstitial lung disease in general, I think if they don't respond to steroids, then you're pretty much stuck. Everything else becomes quite anecdotal in what we use. Of course, we use not as we do add things like hydroxychloroquine and adds anti-inflammatory as azithromycin. But if they don't respond to methylprednisolone, whatever age of children, whether they are infants or older children, then I think you're stuck. You're pretty much stuffed. It's a very bad prognosis.
Yes, sir. So, thank you, sir. With this, we are moving to the second interesting case. This is the case 2. This is, I am seeing the lamps. Okay. So this is the 4-month-old baby. This was full term. Perinatal period was uneventful. He has Caucasian parents. Presented to the local hospital with mild respiratory symptoms, that is the fast breathing and chest retractions. But there was no any obvious failure to thrive. And this is the initial X-ray. So here, at this much information, Dr. Nitin, what is your first clinical impression at this much of information?
So if a child, like a 4-month-old child, comes with some persistent mild respiratory symptoms like fast breathing, chest retraction, so I'll take some history, whether there is some noisy breathing, whether there is some aspiration problem, regurgitation, or choking while feeding. So I'll take these history, whether it's a limp child, and possibly at this point with persistent tachypnea, we will think of one. There could be interstitial problem. 2, there could be some neuromuscular problem. That child is having silent tachypnea. Or there could be some aspiration, silent aspiration. So I'll think of those lines with these history. And then this child came with this, probably had some acute illness, and this X-ray actually shows there is a pneumomediastinum with the small pneumothorax and subcutaneous emphysema. So maybe this is X-ray during acute illness. But apart from that, as of now, I'm not able to see some diffuse ground glass opacities or anything as of now in this X-ray. So other possibilities, some airway malacia. So maybe a child with tracheomalacia. So those possibilities I will keep. But this X-ray grossly rules out whether there is things like hypoplasia or aplosia of envelope. So we'll need further history and further evaluation for this child.
Okay, thank you. So leading to the further history, parent report persistent tachypnea and subcostal retractions. Family history were very significant. Mother has similar history during the infancy, and she required oxygen for about a year. But currently she is asymptomatic. On examination to the child, there was no clubbing, but he has the respiratory distress. On nasal prong, he required oxygen, and there was bilateral capitation on examination, and cardiovascular system was normal. So, and in a very brief, Dr. Salini, what is your now clinical impressions?
Okay, so Dr. Nitin has ruled out all structural, cardiac, and all other abnormalities, persistent hypoxia, tachypnea. So this child is going towards something more. With the pneumothorax, I still want to see whether there's a cyst which has burst, some congenital cyst. The only caveat here is the mother's history.
Yeah.
That is the flag here. I will still dig into the detail, want to know more about the family, extended family, sibling deaths or something like that, and a detail more on what the mother had. And now I'll start thinking of very rare familial ILDs, which we've read more in the textbooks, never seen them in our practices. But yes, that's where I'll think about.
Okay, thank you. So moving ahead, this is the child was treated as a lower respiratory tract infection at the treating unit, but there was symptom was persisted. Chest X-ray was just repeated few days back. Here I want to invite Dr. Biju Thomas. Now, what is your impression by this much informations, and what can be the ILD at this point of time?
We have a chest X-ray here, which is a bit rotated. As you see, the trachea is a bit to the right side, and the right costophrenic angle is cut off. And there is a bit of differential lucency. The right side appears a bit more hyperlucent compared to the left. Again, could be due to the way the X-ray is taken. Given the history, everything was treated for LRTI says, but there isn't any nasopharyngeal aspirate confirmation of any viral etiology that we see. Again, the symptoms are a bit non-specific as well. If you consider this was an infection, I would probably pass it over some post-infective kind of change. Can you just go back to the X-ray 1 second, please? But we are also concerned about the family history of the mother being, that's something very striking.
Yeah.
So in that context, it depends on how the child is. If the child is persistently tachypneic, persistent hypoxia, then I would consider further workup.
Okay.
Yeah.
Thank you. So moving ahead, this is the CT scan film from the patients. Dr. Krishna, what is your interpretation from this CT scan?
Yeah, this is lung window. So you can see the cuts from the upper part of the lung and some middle and lower parts. So you can see by gross looking, it is a diffuse process involving bilateral lung fields. Okay, and there is some amount of granulosing, but it is not specifically feeding into any type of ILD, infantile ILD like NEHI or so. So other maybe at this age group, infancy and the family, mother having a similar illness. One other point is why, if it is surfactant protein deficiency or any ILDs, infantile ILD, why the mother is now become asymptomatic? That is one of the other questions that I will think of. And with this, I will keep infantile ILD as a first possibility. For that, I need to, because child is well, growing well as well.
Yes.
So first, because of the family history, I would first look for genetics.
Okay.
And then if we're still not getting an answer, then I will think, do a bronchoscopy to look at the valve for any material. And then lastly, I would...
Okay, Dr. Krishna, we have to move forward. So thank you. I agree with your findings. So in this case, the biopsy was done, and the lung biopsy showed the possibility of the surfactant protein disorder. And on the genetic test, it was surfactant protein C deficiency was found. So I will not ask now. So this was the follow-up of this child. So he has received the 3 course of the methylprednisolone pulse, and again the oral steroid followed the SCQ. Child was been off oxygen after the next 8 months and lost to follow-up 3 years. And again came at the 8 year. This is the CT scan and X-ray PFT at the 8 year of age. Or again, this is the PFT and the CT scan at the 17 year of age. He remained asymptomatic. So this is the last question I would like to ask. I want to bring again our lead discussant, Dr. Satish Rao sir. What is the challenges in diagnosis and management of such cases, especially in infancy?
Thank you. Again, the clinical presentation is non-specific.
Yeah.
And if the clinical signs are out of proportion, they are not in keeping with the common conditions that we come across,
Okay.
then we have to suspect interstitial lung disease. So this is quite an interesting set of families. So the mother had presented to my predecessor, I can see Gary in the audience, Dr. Weller, about 20 years back.
Okay.
And the child now presented to me with a similar sort of symptoms. And when mother brought him first time into the clinic, she walked into the clinic, she was completely well. So we had to do biopsy because in those days, the genetics tests were not available in the UK, so we had to send the sample off to Germany. And after some time, Great Ormond Street started to do it. Now, obviously, we would go for genetics and not biopsy these days, but we biopsied. And interestingly, we were able to dig out the slides from the mother. That was about 20 years back. And we were able to now give her a diagnosis of hereditary protein C deficiency as well. So then he moved to Northwest, lost to follow-up, then he came back to us at 8 years.
We have already done just 1 minute.
When they came back, now the mother is in a wheelchair and oxygen dependent. So that is how they walk into the clinic. So he is 8 years of age. In that 8 years, mother has progressed. And then she passes away about 2 or 3 years later. So she dies because of this condition. So now I have a youngster. I mean, now he's no longer my headache because I've transitioned him. But then I spent about 3 or 4 years scratching my head on what to do. Now he is well. The CT has shown improvement. The lung function is stable. But then that is how his mother was. Now what is the pattern he is going to actually follow is $1 million question. So we have taken him off all the treatment. He's not on steroids because I don't know whether keeping him on steroids would actually alter the course of his illness. So familial interstitial lung disease is very variable. There is emerging literature on it, but still we don't know. So the fact that these kids tend to improve do not mean they are out of the woods. So we don't know what happens, what happens to the disease process in their 20s and 30s. Because with this condition, they can present in 30s with severe respiratory failure. And in fact, there are case reports of death in third and fourth decade. So, we're still learning, and the fact that these kids actually improve may not mean much. So I think we need to continue with the surveillance.
Thank you. So by these two cases, children interstitial lung disease is an important cause of hypoxia in children. Its a clinical presentation is highly variable. A detailed history and clinical examination is the key because it also helps you in making which investigation should be done, and a stepwise diagnostic approach is desirable and more meaningful. Thank you everyone, our panelists, for giving your insights.
Thank you all of you.